attendee on this webinar and you can hear me, please raise your hand on your GoToWebinar dashboard. Great, looks like I'm being heard. So, in the spirit of this being kind of peer-to-peer sharing, I want to encourage all of you to enter your audio pins so that after our presenters are done presenting, that I can unmute you when you raise your hands if you have something to say, and the whole audience can hear you. So with that, I want to make our first presenter, Debbie Dumont from the Walla Walla Department of Community Health. I'm going to make her the presenter. She has a PowerPoint presentation. Debbie, you should be able to show us your screen now.
Have you got it?
And we do have it. So everybody, Debbie is going to give a presentation on Walla Walla's most current or most recent effort at rewriting their local homeless plan. So take it away, Debbie. We'll give you about 15 or 20 minutes and then open it up for Q&A.
Great. My pleasure. Thank you, Jeff. Walla Walla County, as everybody else, had a 10-year plan that needed to be updated. So we've embarked on that process probably in 2014, beginning to find somebody with some expertise who could maybe help guide that community process, because we really were invested in it being a community process and also data informed. So we, after much searching, enlisted the help of the Corporation for Supportive Housing. It was not an inexpensive venture, but between our local document recording fees, for which we allocated some dollars, and the City of Walla Walla, who happened to be a newly entitled CDBG community, they identified updating the 10-year plan as part of their priorities. So we did that in partnership. So what I'm going to talk to is really what that process looked like. We employed Corporation for Supportive Housing to do two things. And I'll kind of go through this fairly quickly. We wanted first a system analysis. We wanted their assessment of what currently existed in Walla Walla, what that utilization looked like, and we wanted their input on recommendations for changing or reallocating resources. And then we also wanted an opportunity for community input. We had a history over the last 3 years of community engagement to increase awareness about homelessness, and we were seeing 150 to 200 people come out for these community events. So I wanted to capture that audience again for input to the plan. And we also did some small work sessions, smaller input on a couple of particular topic areas. So the system analysis that was done utilized data from the Homeless Management Information System. We were able to pull data from that, and when there was data that Corporation for Supportive Housing needed or wanted, Commerce staff was extremely helpful in helping us pull some of that deeper data. So this is what they looked at. What was the need in the community, and how could interventions best align with those needs? So the findings from that were in a couple of ways. The number of people who experienced homelessness over the course of a year, and part of that looked at our annual point-in-time count, and what were the experiences of those people who entered and exited the system in the last year. So for Walla Walla, that meant that we had 658 people who experienced homelessness in a year's time. So the system analysis looked at where were people living before they entered the homeless system, what intervention did they receive, and where were they living and where did they go when they exited the system. So a system map was created. This is a pretty data-filled map, but they provided a breakdown to that, and we had opportunity with Corporation for Supportive Housing staff to meet with them on several occasions to go over the data and go over their findings before we ever did a community meeting. And then it broke it down. Basically, it looked at every system in our homeless housing system, identified where people came from. Those who entered emergency shelter, you'll see only 21% were literally homeless. 15% came from another emergency shelter setting. And then where they ended up, 45% who exited emergency shelter went to another homeless situation when they left. We had some unknowns, so it wasn't always captured where people went. And then 38% of those who left went into some kind of a permanent housing situation. So the same thing was done for transitional housing, supportive housing, and rapid rehousing. And this gave us a picture of what the system looked like. And from this data, they helped us to look at how could our homeless system in Walla Walla best align with the interventions and needs in the community. So they took the data. In our case, this was data from 2014. They applied some best practice response and strategic system responses and looked at projections for the coming year. So part of the goal was to right-size our system, and we asked for their input on this very specifically, and thankfully we did, because they did an analysis that was, I think, beyond our scope to do as county staff. So they began to look at permanent, the goal being to move people to permanent housing as quickly as possible and help people move out of homelessness quickly. So looking at permanent interventions of diversion, permanent supportive housing, and rapid rehousing, and also looking at temporary interventions, places that people could live before they were able to find permanent housing. So of the 658 that we had in the system in 2014, we looked at what interventions would help those individuals. And these are some assumptions. These are going to sound familiar to everyone because they've been topics of conversation probably since the HARS Act got reenacted. So the assumptions were that diversion is a strategy to be included, permanent supportive housing being a diversion, or a permanent supportive housing, and really geared to those who are chronically homeless who need more permanent supportive housing, putting those who have the highest barriers in permanent supportive housing. And then rapid rehousing, as we're learning along with everyone what rapid rehousing is all about. It's really getting people into a housing situation strategy that can get them out of emergency shelter and transitional housing models or settings. And then also the definition of emergency shelter and transitional housing, kind of with that 30-day window for people who can't be diverted from the homeless system and don't directly enter permanent housing from literal homelessness. They need a place to go while they're waiting permanent housing. So the system analysis told us that we had 41% of this total who needed diversion, 6% or 39 people needed permanent supportive housing, and 53% needed rapid rehousing. And some of those folks, 44%, needed a temporary place to stay before they were able to return to permanent housing. And with that analysis, we kind of got a picture of what our availability was in the community currently. So you can see we had lots of emergency shelter beds, transitional housing beds. We had a fair number we had some rapid rehousing slots, 54 permanent supportive housing beds, and 51 slots or dollar allocation. Again, it's a little bit difficult to identify those slots, but it's a reflection pretty much of how many resources were spent in those areas. So from here they did a projection, the need for permanent housing. Diversion slots, they show we had 51. Their assumption was that we needed 273. So we had a shortfall in that area of 222. Permanent supportive housing beds, we have existing stock of 165. That's not actual beds, but it's more like bed nights. There was a pretty complex calculation that went into this, and their estimation was that we actually have more permanent supportive housing beds than we would need in our system. Rapid rehousing, again, you'll see 218 existing, and their assessment was that we were short 128 for rapid rehousing. And then the right sizing piece comes in, what does that look like? So just presented in a little bit different format with need and availability. So this is what that transition system looks like for permanent housing. This is their allocation recommendation. Again, the same was done for temporary housing, showing that we were way over. We have more emergency shelter beds than they project that we need. And overall, we had 787 bed nights, essentially more than were needed. So that began some conversation. This data was presented in a community meeting. We had about 150, 200 people show up at our community room at our fairgrounds. I can tell you that I happened to drive the two consultants from our office to the fairgrounds, and they had never been to a community meeting for 10-year housing planning where so many people showed up just to talk about homelessness. We gave an overview of the old and new paradigms around ending homelessness, an overview of the current system and the data, and we provided opportunity for community conversation. We had people lined up. You can see here we had several people lined up at the microphone to testify, share their stories, share what their vision was, share their dreams. And we had people capturing everything that was said that night. So we had some key themes that came from that. I'm not going to go into the details of that. I really want to look a little bit more at the process than necessarily the outcome, but we did capture the key themes, and notes were taken on every comment. There were some quotes that were pulled from that led to some of those key findings. We had people who were homeless and had been homeless and looking for help. I was up front kind of facilitating this and could see connections being made at the back of the room by service providers who were doing outreach at the time of the meeting as well. The second day we did what are called fishbowl discussions, and we gathered experts in the community to discuss a couple of topics that had not been well addressed in our first 10-year plan. Those were specifically healthcare and income progression. The fishbowl was a smaller group of about 30 individuals who were invited based on their expertise, knowledge, and experience in homelessness and the particular areas of healthcare and economic or income advancement. And it was a facilitated conversation. We had people in the middle who started that conversation, and everyone on the outside had opportunity to give input and speak to the topic as well. So we had experts from a variety of different fields. From that, we identified gaps and opportunities for each of those areas. And the same was done with income progression. We had a little bit different group in the fishbowl than we did for the healthcare. And again, from that, identified gaps and opportunities. And again, some quotes from that day were included. From this, Corporation for Supportive Housing helped us come up with some recommendations, using best practices, using all the projections, and using the input from both the community discussion and the fishbowl process. So what we received from Corporation for Supportive Housing were 6 basic recommendations. The first one was to increase diversion to prevent homelessness, and some specific recommendations around this, looking that a very high percentage of people who entered the homeless system were not literally homeless at the time that they entered. Many of them were living with family and friends, or had been living in a rental situation without subsidy. And we needed to just shift resources to keep those people from ever entering. Also looked at the chronic homeless population. At that point, we had 35 in the system that were chronically homeless. Their belief was that given the community interest and community engagement, we should create a goal to end chronic homelessness in 2016. You can imagine that we took a deep breath and went, okay, we'll consider that, and ended up selecting that as one of our goals for our 5-year plan. In fact, we have incorporated all of the goals from this almost word for word in our 5-year plan. The third recommendation was to decrease homelessness by 50% and not do it in 5 years, but to do, or not do it in 10 years, but to do it in 5 years. So our new plan is a 5-year plan, and we are working on a weekly update of progress to the 5-year plan. So we're reporting back to the community on a regular basis on where we are in achieving that goal. The next recommendation was based on really their reflection that the community of Walla Walla is really, really engaged. And we had some level of engagement around possible strategies that weren't related to ending homelessness, but more about providing services to people who are homeless, and some perceptions and strong opinions about whether we needed an encampment for these 32 people who are chronically homeless. So their challenge to Walla Walla was they think we can be a national leader. They think that Walla Walla has the will. The fact that so many people came out to talk about this with great passion was part of that. Investing time and energy, and the community really has the ability to pave the way. And kind of harnessing the community interest that was demonstrated. And there were some specific strategies that they helped identify for how to harness the community in the business sector. And some things are being done in Walla Walla that they wanted us to build upon, and some suggestions in how to expand upon that. You'll see even engaging landlords, some of those things that we're required to do in the Consolidated Homeless Grant. But we have some unique things as well. Walla Walla has an ambassador program where 2 college-age young men were hired last summer to be an active presence in the downtown with incredibly fabulous results. And those are happening again this year. Again, some advocacy pieces around the Medicaid benefit and coordination and advocacy with the healthcare, linkage to the healthcare sector in the plan. And we've made some strides in better engaging our healthcare community. And the final one was to look at employment and how to engage the employment sector in the plan. And we've got a whole part of the plan that's related to income advancement and collaboration with and conversation with our WorkSource office locally and DSHS. So that's what our planning process looked like. I think I haven't taken up too much time, but wanted to just give a sense of what that has looked like. We incorporated all of this. We had one piece that wasn't currently in our system specific to youth homelessness. So our 5-year plan looks like the recommendations that came from this process, and we've added a priority for youth homelessness because we didn't have anything in our system. We needed to add that piece. Any questions?
Wow, Debbie, that was amazing. Thank you so much. I'm getting thumbs up all around from my commerce colleagues around me. So I want to invite the attendees to raise their hands on their GoToMeeting, GoToWebinar dashboard, and I'll unmute you if you've entered in your PIN, or type in your question. And to kick things off, Debbie, I loved the inclusion of the healthcare fishbowl in the planning process. I thought that that was so relevant to topics that are under discussion right now, especially around the Medicaid waiver, and so all very relevant. Can you talk a little bit about what the reduction in shelter beds looked like in the community? So I know that CSH proposed that you had an excess of shelter beds. Can you talk a little bit about how you made that shift amongst the service providers in the community?
Yes, we, at the time that this was done, we had 3 emergency shelters, a domestic violence shelter, a women's shelter, and our Christian Aid shelter, kind of a rescue mission shelter. And for a variety of reasons, we were looking at the ongoing operation of the women's shelter, and we determined that the Christian Aid Center they were willing to open up some beds for women and women with children. So our standalone women's shelter actually closed at the end of December, and we worked really closely with that shelter and found, of the 18 beds, I think as we approached the end of the year, interestingly enough, we found that 6 of the women there had not been homeless at the time they entered and had come to Walla Walla with partners or significant others, and relationships ended, and they were simply assisted to return to their home community where they had resources and support. We have also been able to work a lot with diversions. We know that we have some challenges in our shelter in terms of shelter eligibility. We were able to identify that it's difficult for men, single men with children, and we've got a good place for intact families, but single men with children in particular have a difficulty finding place. We're still struggling a little bit. That's created some challenges by closing some of those beds, but we're finding greater successes with diversion. We're finding greater successes with rapid rehousing, and with the implementation of our coordinated entry, we're getting referrals to permanent supportive housing that are really those people who need permanent supportive housing. I think one of the findings was we had a permanent supportive housing program that was entered into by people who maybe didn't need that level of assistance. They were very successful. They were entering some to home ownership, and maybe weren't the people that needed permanent supportive housing. They just needed rapid rehousing.
Right. Yeah.
So part of it was a learning opportunity about who goes where, and some of the permanent supportive housing bed strategies, I think, came because we had a lot of people leaving very quickly and leaving to permanent housing solutions that weren't supported. So we've begun rethinking that and getting people into permanent supportive housing who need to be there. We've opened up some more permanent supportive housing beds for individuals with chronic mental illness. So we've done a couple of things. We also decided that one of the things that we needed to do was create more housing vouchers and permanent supportive housing vouchers. All of our permanent supportive housing for single individuals was in a shared living environment, which isn't appropriate or suitable for everybody who needs that level of assistance. So we took the bulk of our $2060 this year and created 10 housing vouchers in coordination with our mental health provider, who's providing supportive services and case management. So far we've got 5 people with vouchers. 4 of those are leased up, and 1 is looking to get leased up. Like many communities, getting willing landlords is probably the biggest barrier to getting those folks leased up.
Yeah. Debbie, we have just a minute or two more before we switch over to Mike Parker. I did want to ask you this question from the field. Do you feel like, given the size and capacity and the realities in Walla Walla County, that you could have only done that with a consultant? Or do you think you could have pulled this off on your own? It sounds like the consultant made all the difference in the world.
Oh my, the consultant was worth every penny that we paid, and we knew when we were looking into our budget year and determining our allocations for our RFP, that we set aside dollars specifically to pay for a consultant. At the time that we did that, we didn't know who that was going to be. But fortunately, with the partnership with Walla Walla, it was money very well spent for us. The whole system analysis was not something that we had the capacity to do.
Right. Great.
And there was some benefit in a community where there's, I don't think that Walla Walla is alone in having disagreements about what the best plan is, and some finger pointing about, well, the county hasn't solved the problem in 10 years, somebody else needs to take the reins. We had a lot of that happening at the time, and it was really helpful for us to have an outside professional third-party entity to kind of share some of that message and give credibility to some of the priorities that we've been trying to work on.
Wonderful. Debbie, I have a request from the field that we distribute your PowerPoint. If you wouldn't mind sending that to me, I will send that out along with my webinar notes that I'm going to send to all of you.
Absolutely.
To the group. Debbie, thanks so much for your time. It's 11:30, which means it's time to switch gears, and I feel like this topic is not done. Perhaps we could have a future webinar dedicated solely to this topic, because it seems huge, and your process was so well thought through that it seems like there's some more exploration. So hold on to that concept for maybe a future time. So Mike Parker, I'm going to make you the presenter.
Okay.
And I want to introduce you briefly. Mike Parker is with the Whatcom Homeless Service Center, and I've asked Mike to talk about the switch from first come, first serve service provision to prioritization of the most vulnerable people. So, Mike, you're the presenter. Take it away.
All right. Debbie, thank you for your presentation. That was interesting. I was listening with rapt attention, so hopefully we'll be able to keep that interest going. So for those of you who don't know Whatcom County, we're in the far northern corner, and we border Canada, which provides for some interesting situations for persons experiencing homelessness. And we are kind of a mix of urban and rural. We're still considered a rural county, but obviously we have kind of a larger urban center. So just by way of context. So what I'm going to talk to you today, if any of the folks on the call were at the Conference on Ending Homelessness, I was part of a panel group, that talked about coordinated entry and really looked at shifting from first come, first serve, which is the way that we had done things for a very long time in this community, and shifting towards one, coordinated entry, and then two, vulnerability assessments as a means to prioritize scarce resources. So that's what I'm going to talk to you a little bit today, and so part of it will be a historical journey and then kind of get to where we're at now. There we go. So the first thing is when Jeff asked me to present on this, and we didn't talk about this much in the presentation at the Conference on Ending Homelessness, but I think it's valuable to talk about. Why would we do this? So really the first thing that comes to my mind is why we do vulnerability assessment, not just because it's the best practice, or not just because it's advocated for by HUD or now by Commerce, right? It's because we have a resource gap. If we had enough housing resources, whether they be permanent, transitional, rapid, for everybody, we probably wouldn't have to prioritize. But really, we've had a resource gap for some time. Our point-in-time count, just for reference, is not too dissimilar to Walla Walla's. We have 719 persons in our last point-in-time count. So that can give you kind of an idea of our scope, and we don't have near the resources for that. So given that we don't, and we continue to work on development of those, we need to find a way to prioritize those resources. One thing that we found is that in the first come, first serve model that we had, and I'll have another slide that shows you how many different agencies we had working on homelessness, that system actually favored the least vulnerable, the most put together, the most able to check in, for example, if that's a requirement to stay on any kind of a wait list, and to navigate complex systems. That favors the most put together. And when we're in a situation of scarce resources and looking at what happens as those most vulnerable and the chronically homeless stay in the streets, their health was worsening. People are dying, and there's a kind of a human crisis involved. So for us, there's a couple of reasons, not just the best practice, but we think that ethically we really should be going and trying to target some of those resources to those that need it the most. So employment of vulnerability assessment is one of the key ways that Whatcom County has moved to target those scarce resources to those that need it the most. Another thing that we found in this process, and it has become a reason about why we do this, is that that process of a vulnerability assessment really deepened our conversation with people. That they are challenging questions, there's no lie about that, and some will even consider them invasive. On the other hand, what it does is it gives the folks that are the case managers a lot of information about people, their needs, what their strengths are, what their barriers are. And how that has become particularly helpful is by knowing those people a little bit better, I think we're going to be able to make better housing placements for them. So, and then my last point on this is that this is a step, and I think I alluded to this, but the real answer is housing. So we know that vulnerability assessment has its place in our community system. It has a very valuable place, and I'll talk a little bit about how we came about that. But we know in the end the answer is housing. So while we use this right now, we're also looking to continue to develop, whether that be bricks and sticks and making our own buildings, partnering with Commerce on innovative approaches, or getting additional funding for our community. We have to be doing both things at once. That's the only way that we can kind of address the issues here. So here's a little snapshot about kind of what our coordinated entry system looks like. For other folks that have systems, I'm sure they're pretty similar. And what I did is a little purple box that adds that vulnerability assessment in there. So this was a system that we evolved to, and I'll go into some of the history. And the vulnerability assessment, of course, then comes in during a targeted screening. So we have obviously a common intake. And then to that, we've added that vulnerability assessment. We do that prior to going into the housing interest pool. Some people are diverted directly out of that. And we don't serve in our community. We don't have the ability, unfortunately, to serve folks that are doubled up. We do have some limited prevention services. But in general, we can't serve those folks very well. So I might refer back to this. So our system has this variety of different programs. In the Homeless Service Center, we are housed in the Opportunity Council, which is a community action program. We have lots of existing systems or housing providers in Whatcom County. And some of these are listed on here. So what life might have looked like before would have been the darker colored ones are our direct partners. And a person would have had to go to all of those places to be on their wait list. So obviously, by doing coordinated entry, intake, and assessment, we're able to do all those referrals. It's a lot easier for folks. So I'll go into a little bit of the history and kind of a little bit of the journey. I think that part of the theme of this call is try and give folks a sense of the process. And so this is certainly a process. Some even call it a journey. So I'll try and do this succinctly. So pre-2008, of course, my department didn't even exist. And you had 7 or more wait lists with individual agencies. So if you were a person or a household experiencing homelessness, you would go and sign up on all these lists, and you would follow whatever their check-in requirements were, usually once in every 30 days in order to stay active. So pretty confusing, pretty challenging, and literally running around town. You could spend an entire day or a week just keeping active. 2008, my department's founded in the Opportunity Council with a different focus, because really what we do is we're kind of a hub and spoke. If you saw that previous slide, hub and spoke, where we will work with our county partners and kind of allocate to each of these partner agencies funding, 2060 funds, CHG, whatever that might be. So my department is founded, and so our work begins to consolidate on one wait list. By the way, that kind of movement happens over 2 years. So there's lots of conversations, there's kind of getting people on board. Well, I would say we had a collaborative environment. there's still a lot of work to do for folks to be able to kind of move towards letting go of maintaining and controlling their own wait lists. And we still continue to work on that. But the first iteration of that in 2010, so we did have that, we had that one wait list, but we were still using first come, first serve. 2011, we attended a Hearth Academy training, and you heard Debbie mention that, and the body of knowledge that comes out of that. Obviously, guiding principles are starting to arise, right? Prioritize based on vulnerability, and using a common intake form really helps communities and helps our consumers be able to access services. So the next stage in our journey, if we were going to have this kind of consolidated list, we needed to be able to consolidate our data. We needed to be able to share these people in HMIS. So we created with our partners in commerce a Whatcom Housing group and then have a MOU. So we're essentially able to share all of the data about the folks that we serve in Whatcom County. That was absolutely critical. And then the last thing we did is actually creating a housing pool, which is a database incorporating diverse data. And actually it's different data from 20 housing programs and 13 agencies. So that's a little bit of work to be able to get all the program specifics in there. But obviously necessary so we can make smart referrals. So that's, you know, and that's before we have vulnerability assessment. We start using it first in a pilot project. And we worked with actually the City of Bellingham Police Department with some identified folks who were really essentially constantly being in that criminal justice mill. And so we piloted Downtown Emergency Service Center's VAT assessment tool, and use that to go through and look at needs and prioritize that first group of folks. We like that. The VAT's a great tool. And by the way, I don't espouse any one tool or another. You're going to see we've used a couple. Lots of communities use them. So, but when we were looking to roll this out outside of the pilot project, part of our journey was to kind of evaluate, could we do this everywhere? So we interviewed some users of the VI SPDAT, which we had heard about, and in Utah, Washington, and Connecticut. And while they all said that it wasn't a perfect tool, and I don't think there ever would be, we got the general gist that it was a better way to prioritize over nothing, and essentially we were using subjective meetings to try to talk about people. Second thing is it gave us that objective measure that we were kind of craving, so it wasn't just a matter of who could argue or advance somebody's cause in a meeting. And then the third thing, and a really important piece, is that it was quicker and easier to do on the street. So while we really like the VAT and we do believe that it's a great in-depth tool, the VI SPDAT allowed us to use it in a strategy, and I can't underline how important this is enough, about a street outreach team. So one of the things that we find as we go into vulnerability assessments is you need to be able to go where people are, because a lot of the most vulnerable and the people you haven't been seeing in your doors, that's because they're not able to make it there. And so having a professional street outreach team, and we had a volunteer one for years, so we created a professional street outreach team in 2015, and that has been an absolutely critical tool for us as we, in 2015, we also employed the VI SPDAT and now do that for all entrances into our housing interest pool. What that allows us to do is obviously people still come to our offices and come to a couple of other sites where people can get that intake and have that vulnerability assessment. But what the street outreach team can do is literally take that into camps. We can go and respond to calls of concern about individuals and for people who really are just so suspicious of systems that they weren't getting served. And the great thing about our homeless outreach team with their focus on the relationship is they're able to do that over time. So we don't have to do that the first time we meet somebody. We may build interactions over 20, 30, 40 times of just saying hi. Some of them might be coffee. But eventually we work towards that and doing that vulnerability assessment. And a lot of these folks we have been able to prioritize and get in a permanent supportive housing. The last piece that I have on vulnerability assessment and things that kind of on that are informing and kind of underscoring our need is HUD-issued guidelines, which I'm sure you've all seen in 2014, where they're really coming out and saying, you need to prioritize folks for permanent supportive housing programs. And then, as we're all aware, CHG funding too also has this kind of prioritization. So I think for communities, some of us were doing this a little bit longer, over a longer period of time. When I was at the conference, it became very clear some are going to have to do this in a more rushed way, especially if you get these kinds of funding. So I want to allude a little bit on the fact that it was a journey, and I mentioned that in the beginning, and I would say that it is. The whole process of coordinating and collaborating work of a myriad of different partners who serve maybe different folks. Maybe some serve youth, some serve families primarily, some serve chronically homeless single individuals. So getting that all together is a lot like a conversation. It's kind of, and it's something that happens over time. We've done things like had focus groups along the way as part of our process to be like, how is it going, and then realize that we might need to make tweaks. Second bullet on here, and this is a really key thing, and it's both a challenge and a great benefit, is that vulnerability assessments, coordinated entry, it helped us really spotlight gaps. We were able to see where we didn't have holes. As Debbie is talking about, when they do an analysis of their system and they find out kind of, well, where are resources going, where are the gaps? I would say that doing this does too, because what we realized is, first of all, far more vulnerable people than we knew, and part of that was our street outreach team, and we were really prioritizing and finding them and targeting those resources. We found that we had a real lack in permanent supportive housing that was really wraparound intensive, and so we still work on that in our community. The other thing that we have is we had a lot of people that really have some pretty serious medical issues. So obviously, looking forward into the future, Medicaid supportive housing benefit is really appropriate, because it was way beyond the behavioral health needs that we were kind of more used to, and maybe people stereotype that persons experiencing homelessness have, and certainly they do self-report that. We found a ton of people, though, that were just really ill and really had poor connections or weren't getting the care that they deserved. So that's part of this, going through the process of creating a system, is that you're gonna find some of your weak spots, but that can be very helpful too. Another thing for us was developing program criteria in order to effectively utilize the resources that we have. So when I said earlier that the vulnerability assessment and that process allows us a way to get to know the folks that we're serving better, the other thing that when seeing their strengths and the barriers that happen, we're hopefully going to make better fits into which program that they would fit in. So for example, if you have like a scattered site housing program, permanent supportive housing program, versus a really service-enriched 24/7 staffed one, and the vulnerability assessment will kind of give you a number, but it doesn't necessarily always indicate the best. So that forces programs to look at, well, how do we say that this is the kind of person that we need to serve? And you have to do that kind of system analysis like Walla Walla did to find out where are your gaps. So for example, we know we're doing a better job serving families, and we have a priority to do that, but we need more resources to be able to serve our chronically homeless unaccompanied adults. So, and then creating program criteria so that really that is the specific thing. So the vulnerability assessment will say that, yes, we will take the most vulnerable and place them in housing, but we're going to place them to an appropriate program fit. So that's a real value in our community. Another thing that makes it kind of a work in progress is we continue to evaluate this tool. So we're currently using a BI SPDAT 1.0, and we're aware that no one tool can capture absolutely everything. And so we're evaluating the possibility of looking at a 2.0, and some communities also use this for certain programs and then may use a VAT, for example, for emergency shelters. So there might be some kind of a blended or hybrid strategy, but nothing is fixed, forever. This has been a journey, and it continues to be. And we want to see if for example, our tool is not capturing certain aspects of vulnerability, we want to be able to do that. And so that's a continued conversation. The other thing that's really important for us is that we continue to stay in communication. So one of the things, by finding more and more vulnerable people and having those people in housing placements, we're placing a lot of folks with higher barriers, and that brings with it challenges. So in Bellingham, for example, we've had less than a 1% vacancy rate. So we have to, that's a very tough thing to try to get our folks housed that come with a subsidy, that may come with some stigma associated, and some rental discrimination. So those are challenges that we have to go through, and we also realize too that when we try to serve the most vulnerable, we're not picking on the most likely to succeed. We're picking folks that need and deserve the greatest amount of care. That can be a harder sell, and we're ready to do that and ready to partner with our landlords to show the wraparound services we do. But I can't do this honestly and not say that that's a challenge, because it most certainly is. And then the last piece that I kind of wanted to leave with, and how the work in progress is going to continue to be changed, is what happens in the future. And obviously we're looking at a Medicaid supportive housing benefit. I think that will help us with a need that we've seen, which may be an increased need for adult family homes and supportive services for folks that really can't handle the daily living on their own, and may need different assessments. And then, as I mentioned too, we're looking at going to 2.0 and possibly incorporating a youth tool. So our particular tool in our system, that may not capture the youth experience and young adult experience. So we continue to work with our specialized youth partners in what would it look like to have a different assessment tool for subpopulations. So that's a little bit of kind of our process and our journey with vulnerability assessment. I hope I've left some time to be able to do any kind of questions if there's any out there.
Great time management, Mike. Really good. And we do. So we have a couple of questions that have been written in from the field. I also want to invite the attendees to raise their hands if they'd like to speak to the group. We encourage that. One of the questions written in from the field is from Melissa in Cowlitz County. She asks, referencing in one of your earlier slides in that very PowerPoint, who are the people that are turned away in the system diagram?
Oh, right. So I'll go back to the slide that she's talking about.
Yeah.
And launch that back up. Hopefully folks can see that now. So yeah, who's turned away? So in our system currently, we have services to serve veterans that may be doubled up, and we may be able to help them, and we can often serve families. And we have some targeted resources for them. But for other folks that are doubled up and that aren't literally homeless, we have some limited prevention amount. And so if somebody's currently housed, is on a lease, and is just unstably housed, we have a screening for that as well, because we have limited resources. That person doesn't qualify, they may be turned away. And in most doubled up situations, because the only folks on our housing interest pool, like I said, with the exception of families and veterans, you have to be literally homeless. So there are people who are unstably housed or are couch surfing that we are unable to serve. And so those folks are turned away. We can serve them as a community action agency. We might be able to serve them in other ways, energy assistance, Head Start if they have minor children. So, turned away from our housing interest pool, not from our agency, and not from connections to other services. That's a
great
good question.
Distinction. Yeah, thanks for clarifying that. And how do you deal with cases where it's shown that a client is in need of more rigorous assessments once they're actually in housing, more rigorous than the preliminary assessment that they get in coordinated entry?
That's an excellent question. There are those that would say in the industry that assessment is not a one-time thing. It's not a form that you fill out. It's an ongoing iterative process. And I think that question gets at that. And you're right. So when the referral happens, and say that if we're looking at my slide and you're in the housing interest pool, you get a referral to permanent supportive housing, you're going to go to one of our partner agencies. They're going to do another assessment with you. They're going to do an intake and an assessment, and it'll probably look a lot at life domains and various issues and various supports, which we find helpful. It may not measure like daily living activities, for example. And when I alluded to that, we've had people coming through our system because we are better at finding them. but we need to be able to find the resources. So some folks, for example, may not be able to live independently, may not be able to operate a stove. They may have such intense care needs that they really need a higher level of care than a housing subsidy with ongoing case management. They might need, COPEs or adult family homes. And so that has been highlighted as an issue. We certainly have a scarcity in that. So hopefully that hit that a little bit, that is kind of an ongoing process. But once they get turned over to case management, there's kind of an ongoing process where I think the minimum standard is twice a year, where they're kind of reassessing and then creating essentially service plans around the needs and the strengths that are identified in that conversation that happens with that client and with that case manager, because it is an ongoing process. Things change. Some things get better. The other thing that we've often seen is people in their first 6 months, when they're finding out that they have these conditions, they may actually consume more resource. They may consume more health care because they're getting care.
Right.
So it may appear like they're getting worse. They're not. They're actually getting better, but we are finding out, for example, they may have diabetes, which they didn't know.
Okay, so I want to extend once again the invitation to the attendees. And so far, not getting anybody in. Mike, can you talk more about the conscious decision to kind of start moving away from prevention, and maybe talk a little bit about that fine line between prevention and diversion? I know that amongst my colleagues here at the office, often the line is blurry. It's hard to tell. Are we talking, when does prevention stop being prevention and become diversion, or vice versa? Can you share a little bit of your insights about that?
Sure. Yeah. So diversion services for us, of course, also include it may include like rapid rehousing or deposit help. Some folks that get into SSVF, it may get diverted from like a permanent supportive housing, and we may be able to help them in some other way. So for us, prevention, part of it has happened through the funding side, where literally there's less and less money available for prevention, and there's more and more for permanent supportive housing. That also tends to align with our community's plan to end homelessness. In our own kind of analysis of what resources we have and which ones we need. When we have scarce resources, there's so many folks that are literally homeless. And when we've done looks at that in the past, prevention could be really valuable, but on the other hand, people often were able to find things even without prevention assistance. And I don't have hard data on that particular thing, but that's one of the key things. Were we helping people and maybe supplanting some natural resource that they might have on their own? And I think that was happening.
Yeah.
And then in terms of diversion services, we're also really interested in some new diversion type services, which get pretty creative and may divert people before you even spit at them to see what options they might have.
Right. And so I think I missed that. Did you say you don't have hard data about the people that are denied prevention assistance and who may or may not show up at a later date in the homeless system via HMIS?
Yeah, what I mean is I don't have it handy at my fingertips to be able to tell you about it. Obviously, we capture that information because we actually capture turnaways as a service in HMIS, so that's a very good point. Yeah, so our data specialist or guru, we do capture that information because we want to see, how effective is that? Are people coming back anyways? Or would they not if we've turned them away and then we've never seen them as an entrance? So having that data in HMS allows us to look at the repercussions of our decisions and our hunches, and then we can find out, are we doing the right thing? In general, we found that we are reducing prevention and skewing more towards rapid rehousing and permanent supportive housing, and so far that has been a really good move in our community.
Great. Do you have a ballpark figure off the top of your head about what percentage of turnaways later show up in the system?
I wish I did. I don't off the top of my head. That would have been a good one. Yeah, I don't.
That is the million-dollar question, of course. As the resources for prevention become more scarce, the rightful concern is that people who really need it are going to get turned away and become homeless. And of course, that's the whole point of targeting prevention with the little prevention funding that's available. And I suspect that this too may be topic for a future webinar. So, you know, Mike, I'm not seeing any further questions. I want to be mindful of everybody's time. We're at 11:58, so we're right at the top of the hour. And I want to thank both Debbie and Mike for taking time out of their busy days to present really excellent material to our lead grantees. Thank you so much for your time. And for all the attendees, there'll be a new agenda coming out for June's webinar at the end of June, so be on the lookout for that. And Mike, I'll ask you to send me your PowerPoint too, and I'll include it with Debbie's when I send out my notes to the attendees.
Sounds great.
Great, and thanks everybody for your time. Have a great day.